Good evening, everybody. This is an intriguing topic and something I had to prepare a fresh talk and review a lot of literature. Spent practically last 3 days just preparing this talk. So it's not one of those talks which is there in my laptop and I open it up and start presenting it here. I've worked hard to make sure that everyone who's here and subsequently listens to the talk on YouTube does get to learn something. In fact, I learned quite a bit while preparing this talk. So I hope I can get your heart rates a little up. I can get you a little pre-excited while presenting here. And to warm up, we'll start with something which you all are very familiar with, but still remains, every time I see a patient, still remains highly underdiagnosed. So we'll start with hypertension. And, you know, the guidelines have been changing repeatedly. Last guidelines have come in 2017, and this is not going to be an extensive talk on hypertension, just about a couple of minutes on hypertension. 3.5% of children have hypertension, another 10 to 11% have elevated blood pressure. Increase in prevalence is due to obesity, and risk of adult hypertension, cardiovascular disease, risk increases in these children. So actually these children are having vascular aging in front of us, and it is premature vascular aging, which we will talk about a little later also. Higher rates are there amongst adolescents and amongst younger children, and 15 to 19, 20% of people have a higher incidence of teenage hypertension. Now the definition is more than 90th percentile, now termed elevated BP. Cutoff points for stage 1 and 2 hypertension are simplified, and BP cutoff points for adolescents more than 13 years of age are the same as in New American Heart Association and Cardiology hypertension guidelines. So things have been simplified to make it straightforward. You know, you're looking at a number basically at 120/80 or 130/80. These are the numbers you're looking at to classify as hypertension, and less than 90th centile is less than 120, less than 80. Stage 1 hypertension, that is more than 95th percentile, is 130/80 to 139/89, and stage 2 is more than 140/90. Previously, tables have been very complicated, but the newer guidelines, which are freely available on internet, are a straightforward table like this. You have systolic blood pressure, diastolic blood pressure for boys and girls, and age. Height has now been eliminated from the table. So this is the straightforward table. You could pull up and print out a simple one, keep it on your table available to you, and measure the blood pressure. So who requires blood pressure measurement in your outpatient? And this is extremely important. Anybody who's above 3 years of age, whom you're seeing, requires one blood pressure check once a year. And believe me, almost every single patient who comes with hypertension, and I'm the lucky one, is already diagnosed by the time they reach me. Very rarely I end up being the first one to diagnose. They have had multiple physician contacts, and it gets usually diagnosed in the emergency room where they present it for some other reason. So you need 3 oscillatory BP measurements, not oscillometric, to classify a person as having hypertension. If you detect it the first time around, all you have to do is lifestyle counseling, because that's the primary cause. I will request only one question to be asked to the family, and that is, who amongst the parents or grandparents and at what age had coronary artery disease or hypertension? And that is the most revealing question, which will give you an insight on when your patient sitting in front of you is going to get hypertension. And if the lifestyle is accelerated, as it already is, we all know, they're going to get it at a much younger age. Trust me, I end up seeing teenagers with blood pressure 180, 120, almost once a month. So there are 2 new terms which we need to be aware of: white coat hypertension and masked hypertension. White coat hypertension is when they have hypertension because they are in a medical facility. These patients do not necessarily need to be treated when they are diagnosed, but they are at a higher risk of type A personality, and they are at a higher risk, therefore, of hypertension early adulthood. So white coat hypertension is defined as BP more than 95th percentile in the office or clinical setting, but less than 95th in the ambulatory BP monitoring. And masked hypertension is the reverse. In your office, he's going to be normal, but when you get the ambulatory BP recording done, it shows episodes of more than 95th percentile blood pressure. That's masked hypertension. So the question is, how do we get ambulatory BP recording? Well, if you need help with that, a couple of weeks later, I should be having facility of ambulatory BP monitoring at our place. The equipment is relatively expensive. Pediatric cuffs are relatively difficult to get, but we have the facility available. It's on its way, and we should have that for you, for your patients, in about 15 days' time. That's all about hypertension. Now, related topic and close to it is obesity and the predictability of coronary disease. I'm not going into lifestyle management. You all are much better than in that as compared to me. I'm talking about when you see an obese patient, you're worried about the child having increased weight and diseases related to that. But as a cardiologist, I ask one question. Who in your family has coronary disease and at what age they got it? And in fact, that is totally revealing towards when this child will get it. There are enough studies, enough number of studies which say that the rise in BMI is related to coronary disease in teenage years. It's related to rise in triglycerides. It's related to a lower HDL level in teenage years itself. BMI predicts angiography-proven coronary artery disease. This is not a small statement to make in young adults. The risk of coronary artery disease is 3 times more common amongst those adolescents whose BMI was above 86th percentile. So if the BMI is high, this young adult could have an MI at the age of 35, 40, 45 years also. The risk is 3 times higher. And the rise in BMI in adolescents proportionately raises the risk of CAD, coronary artery disease, even up to 7 times. There have been very large-scale population studies in the West about the millennial population, that is those born around 2000 plus or minus 10 years, and they predict 30% of them will have lifestyle disease, and therefore obesity, hypertension, diabetes, and coronary artery disease by the age of the 4th decade, that is 35 years of age. 2035, when they hit that year, when we hit that year, our teenage patients will be having coronary artery disease. 30 to 35% would be at risk. How do we tell a teenager that your arteries are getting affected? Because it has been studied what will make an impact. You have spoken, all of us have spoken to teenagers, and there is no impact on them about food, diet, exercise, anything you tell them, it's not going to make a difference. What has been studied and found to make a difference is show them a picture which says, see, these are your arteries which are affected. I'll show you something related to that. Increased carotid intimal thickness, CIMT, is an early marker of atherosclerosis. Arterial wall thickness in obese kids, this is the abnormality detected. Abnormal accumulation of lipids in the vascular wall is associated with obesity. And the good news is this is reversible. So if we find the CIMT, carotid intimal medial thickness, to be increased, and he changes his lifestyle, you can show it to him that this has decreased now. What does it look like? This is what it looks like. This is the carotid vessel. This is the wall here. This is the wall here. And there is a software which comes with this imaging to measure this thickness. And there are normal values for teenagers. There are abnormal values. All that data is available to us. This is the lumen. This is the near wall, far wall, the thickness between the green and red, which is measured in millimeters. And this can predict the atherosclerosis which will happen. Carotid artery intimal medial thickness in young adults with family history of early coronary artery disease or family history of coronary artery disease. The arterial wall abnormalities are present at an early age in offsprings with family history of CAD. CIMT measurement is recommended in this subgroup. You could get these tests done. Now, this is a special equipment and software, and we will be having this available in September onwards. In case you would need it on your patients, we could be having this for your patients. Now, CIMT in the offsprings of CAD cases had increased CIMT, offspring with family history of CAD, had unfavorable lipid profile, direct association between CIMT and triglyceride concentration, and family history of CAD is an independent risk factor for CIMT to increase. That means unrelated to obesity, lifestyle, exercise, anything, the CIMT will be increased, unrelated to those factors in the patient, but independently related to the family history. So this is very important, that even if the child is not obese in front of you, you could tell him that there is a higher chance because you all are eating the same food. So the nurture part of it the same, the nature part is genetically inherited, also the same in the same family. So I'll touch very briefly on some controversial issues of one condition which you can label as congenital heart disease. But I don't label it congenital heart disease because it's not a disease. PDA is there in everybody when we are born. There is no defect in the heart that results in PDA. It's the persistence of PDA, which is the abnormality. So there's a lot of interesting information about neonatal PDA, and I want to bring you all up to date with regards to that. Premature baby in the ICU detected to have PDA, and we think that it could be related to, incidentally, this is the most common cardiac condition in newborns. It could be related to this, intraventricular hemorrhage, NEC, ROP, BPD. Now you can look at the slides, but I'll give you a brief idea what's happening in the literature. That we have predicted and hypothesized that IVH, NEC, retinopathy of prematurity, BPD, is related probably to PDA, because PDA somehow either puts more blood in the lung or steals blood from gut and brain, causing these problems. So everyone started closing PDAs 20 years back. You see a PDA, you close it. You give indomethacin. Gut perforation happened in small percentage. Okay, move from indomethacin to brufen. We know how the sequence happened. Western literature said IV brufen. We said oral brufen. We don't have IV. We gave IV brufen to all of them. Kidney side effects decreased when we moved from indomethacin to brufen. But simultaneously, studies were coming out. And they were not small studies. They said that we are closing all these PDAs, but the incidence and long-term outcomes related to IVH, NEC, ROP, BPD, and neurodevelopmental outcomes, none of them are changing, whether we close a PDA or not. So they said, okay, you know, if these are not changing, why do we surgically ligate PDAs? Let's stop surgical ligation. At least one surgery we save on a newborn. It's a very big intervention. So this is as recent as 2010. And 2012 onwards, device closure for neonatal PDA started, at least in term babies. They said, okay, if we are not doing that, let's close whatever we can with a device. And you know, the general feeling is interventionalists want to close whatever they see, they want to put a device in it. So the literature started coming out, okay, we are not doing surgery, which is so morbid in itself. We're doing it with device. Does this decrease the incidence of these? And studies as big as 60,000 patients, premature babies, no change in incidence of IVH, NEC, ROP, BPD, neurodevelopmental outcomes. By 2016-17, we started questioning, are we doing it right? What are we missing in the big picture? It's simply pathologically connected that you have PDA, it does all this, and that results in this condition. If we close it early, it should stop all these or decrease. Some decrease should be there. No decrease. Non-controversial literature, absolutely no change in outcomes. So let's see what happened. Long-term outcome, neurodevelopmental, BPD, NEC, IVH, ROP, PVL, none of them. There is lack of quantifiable improvement in outcomes after PDA closure. So we are on the cusp of science here in front of us. In September, there is the first international conference on premature neonatal PDA, covering full spectrum pathophysiology, new drugs, actually definition of what is HSPDA, hemodynamically significant PDA. There's no universal definition yet of HSPDA. This happened in 2016. Neonatologists and pediatric cardiologists said, okay, let's not close every PDA. Let's define what is a hemodynamically significant PDA and close those. They close those and still there is no advantage or change in these outcomes. So finally, we have literature coming out late this year, early next year. The studies are on, which will conclusively tell us what is that subset of patients who really benefit from PDA closure and the rest don't need PDA closure. Incidentally, you may have this question in your mind, why are these things happening? Because there's a major overlay of prematurity. Prematurity obviously predisposes. These conditions also happen in babies who don't have PDA. PDA only accentuates them. So maybe the contribution of PDA is significantly less. And these are the 4 reasons right at bottom. Maybe there is no true cause-effect relationship between PDA and morbidity. Number 2, are the conclusions of studies unreliable? Number 3, frequent crossover between placebo and control. Number 4, there is a causal relationship, but the closure is not enough to ameliorate the morbidity of prematurity. So we are working on these 4 hypotheses. It's because of this interesting time zone that we are in related to neonatal PDA that I bring it up. And yes, I understand some of you may say this is not, this is a congenital heart disease, but it's a persistence of a fetal circulation into a newborn. And really, this is going to be defined in the next few months. So something new is coming this way. I will not go into brufen and acetaminophen except one thing. There is one fact, this box here. So in some patients, PDA closes when we give brufen, and in others it doesn't. And they studied the brufen levels, and they found that the ones in which it doesn't close, the levels are lower. And so they said, okay, double the dose and see. And they found that when they give oral brufen, the absorption is slower and the levels are higher. And therefore, the closure rates with oral as compared to IV brufen is higher. This is an interesting scientific observation which was made. And I thought I should bring it forth because this is so subtle a point. Usually we think IV should have better results. But PDA closure rate is probably associated with the brufen trough levels. And the trough is much lower in babies when it's given IV, but higher when it is given orally. So brufen oral results in higher closure rates as compared to IV is an interesting observation. I'd like to highlight that acetaminophen, which is paracetamol, which is also used for closure of PDA, is not FDA approved. I'd also like to bring to your attention that there are several studies, and why it is not FDA approved, there is a reason. Because there are several studies which are on the way, which are found an association of paracetamol use in animals during pregnancy with autism. So yes, that's a big piece of information, but there is a possibility, and if you Google search or do a PubMed search, you will come across large number of articles where animal studies have shown this. The question is, should we be giving paracetamol to premature babies or not? Definitely not proven. This is not a rumor. I'm talking about scientific information in scientific meeting. So be aware that that's another piece of information to be followed. So no, we don't have, this is our animal studies. We don't have information about that. So these are rat studies, which are from 2018 incidentally. So there are a lot other studies which have happened subsequently. All have confirmed that finding in animals. Don't ask me. I'm a cardiologist. Nothing about the brain. I have no idea. They are also social beings, I understand. But please ask a neurologist. Ask anybody but me. Ask me about the heart. I'll tell you anything. So from here, we move on to another condition, that is myocarditis. Now, we all know myocarditis. We all have seen, we have had patients who've survived. So what is there new to talk about? So here is a very nice table, I thought. These are percentages in bracket. Only about 40 to 70% of patients will give a history of viral prodrome. Arrhythmias will be there almost in half the patients by history. Syncope in a very small percent of patients. Sudden cardiac death is rare, but is known to happen. And trust me, I have those families sitting in my office for hours, several visits to discover, find out what went wrong. They have a video of their child also in the last 1 minute of his life, but still, obviously, sudden cardiac death is another differential. But I won't be getting into those elements. Symptoms wise, fatigue in about 70%, shortness of breath 35 to 70%, fever in about half the patients, and abdominal pain, rhinorrhea, chest pain, dyspnea, cough, palpitation, diarrhea. Incidentally, Coxsackie virus is the cause. Enteroviruses are the cause, not upper respiratory infections, incidentally. Tachypnea in half the patients, tachycardia in about 1/3 to half, hepatomegaly in about 20 to 50%, respiratory distress. So the signs are very few in these patients. And it is only an experienced clinician like you all, and all of you have picked up myocarditis. And I must say, I'm amongst a group of very good clinical pediatricians, because many times I wonder how was this child picked up by you all? And it has been done innumerable number of times. So I'm very happy to be talking amongst you all and enjoying giving this talk. So we figured out this aspect, which I'm not going to go into and bore you, that every cell, every immune mechanism which destroys the myocardium has been figured out. So we have understood that it's an interaction between the myocardium, T cells, immune mediated from the bone marrow, and cytokines involved, interleukin, tumor necrosis factor, everything is understood now. What remains is that what is happening to the patient. So you will find this algorithm that a patient presents. I'm sorry, the upper part, I don't know if I can get rid of that somehow. Can this be kind of removed from here? I'll try that 1 second. I can put it here, but that'll compromise that. Let me try that. So recent signs and symptoms of heart failure. Then there are some basic investigations. I'm not going through these busy write-ups here, but I'm just confirming one thing. This is the algorithm for diagnosis of myocarditis. It says CMR here. That's cardiac MRI. And it says biopsy here. Your patients haven't had CMR or biopsy, right? When you diagnose myocarditis, they had echo and they had IVIG. Is that right? Yeah. So the diagnosis of myocarditis is confirmed on CMR, suspected on echo, and proven on biopsy. This is the current understanding. The 3 words are very well defined for myocarditis. Suspected on echo, confirmed on CMR, and proven by biopsy. So I tried convincing parents for biopsy. They don't agree for biopsy. Cardiac biopsy sounds very dangerous to them. But it's okay if we don't do biopsy, we don't even have the viral studies to do PCR on each one of those viruses, which is what is needed, and to do all the metabolic studies. So foregoing that, but then MRI becomes a tool which confirms the diagnosis very clearly. I'm sorry about that. I'm trying to move it. Yeah. So what are the biomarkers? Troponin I does not appear to be a sensitive or specific enough marker for biopsy-proven myocarditis. So you may have a suspected myocarditis. You may think it's myocarditis. Echo may show it, but troponin T or I may not be positive, and don't go by the troponin I or T. It's not very sensitive or not very specific either. But it does correlate. If it's very, very high, it does correlate with the need for ECMO. Now, just over the board, what do you tell a parent? Child viral myocarditis, they are like scared to death already. And possibly most of us are also with the diagnosis, but what are the statistics? So there used to be 25 years back a 30-30-30 rule, which I have actually forgotten. But today's statistics are 80% patients will return to normal heart function. Even fulminant myocarditis, they will return. This is my experience too. And I say this to every patient who comes to me with myocarditis. So the intensity of initial illness, which may be fulminant, may require supportive mechanisms, which means ICU stay or even to the extent of ECMO, but it might be very rewarding because the best outcome of ECMO is in myocarditis patients. This is the MRI, and what we are seeing here is this part here, and I hope it can show that, yes, that is the part which is enhanced and seen in various other T1 and T2 modalities, and here on gadolinium also, and is clear as daylight that this is confirmed myocarditis. Now, what happens once myocarditis is there? It could be acute or permanent cardiogenic shock. Patient could end up on ECMO. Every patient doesn't need ECMO. Incidentally, ECMO is there in most hospitals today, and if parents can afford it, and we can discuss that part of it in the discussion group, then their child is likely to survive. But if they continue to be in low cardiac output state, then, and ECMO is not what we need immediately. ECMO is an emergency thing to support the heart and the lungs immediately. But suppose they're able to hold on, but their lactates keep increasing and their output keeps dropping and multi-organ dysfunction happens, then, and they are relatively slow as compared to permanent, then we consider implant of one of these devices. This is only in about 5 or 3% of myocarditis. The rest of all will improve with routine drug management, 95 to 98%. So what I'm talking about is not the routine, because we all are familiar with the routine, but I need to highlight this is a very small percent of myocarditis which will require these. Chronic, again, device implant, and these are all available. Those who are not able to maintain or end up with NYHA class 4 on medications, they may end up with either of these heart implants, ventricular assist devices. Now, this might sound like weird, but we have patients in the city who have been treated with Impella, Pedimac, who have had ECMO and gone home, and who have had HeartMate also. Yes, they are expensive, but you need to know that this is available in our city. It can be given if there is a patient who's ready to get it and take it. This is there. And I'm surprised sometimes that and can't predict which family would want it and would want to refuse it. So we'll just talk very briefly about IVIG and corticosteroids. I just need to mention over the board, corticosteroids are contraindicated in acute stage of myocarditis. I do not use steroids in the first 3 weeks because the immune mechanisms are such that the acute damage is because of the virus, the chronic damage is because it's immune mediated. So suppress the late immune mediated damage by giving steroids, take care of the acute viral damage and the inflammation by IVIG. So if we do not treat with IVIG, the outcomes possibly are the same. And I need to say this as a person who uses IVIG. And why do I say that? Because till date, not one study in adult or pediatric has proven that there is a better outcome with IVIG. Not one study. And there have been numerous studies. Obviously, it cannot be a blinded study for obvious reasons, but it is a case-controlled study, and they have not proven it to be beneficial. So IVIG is more looked at as an anti-inflammatory, antiviral, immunomodulatory drug rather than immunosuppressive. It's not an immunosuppressive. So if the myocarditis is really bad, suppose we have continuing damage in spite of IVIG, that means the function decreases. IVIG doesn't improve the function immediately. So if we give IVIG and we say today is 20, tomorrow is also going to be 20. And the patient may go home with 20. And how come? We vasodilated him enough that the heart is able to take the load and the functioning of breathing and the functioning of moving around or feeding. The baby is small enough. So medical management helps take care of, and with the same output, have the same function, better output, able to manage the body's functions. That's what we do during that period. The improvement in function is always later. So steroids are immunosuppressives, as we know, also anti-inflammatory, and landmark study by Mason et al. Proved that there was no improvement in survival. In fact, the outcomes were worse when it was used acutely. So I do not suggest giving IV steroids or oral steroids in the first 2 weeks or 3 weeks. The studies where it has been used acutely is with prednisolone and azathioprine, which is an antiviral used as a immunosuppressive here. So there is no antiviral till date which is available to us freely, which can counter the viruses which cause myocarditis. We hope it is in the process. Now, I'm going to introduce you to a term, which is why I brought forth myocarditis, and the term is GDMT, guided medical treatment. So what happens in heart failure once the patient's out of the hospital? How do we manage? It's the same drugs you see, digoxin, Lasix, Furoped, and you see NVAS, and then you see some other new drug. So now it is algorithmic. It is GDMT, guided medical treatment and therapy. Outcomes have been correlated with the use of GDMT. It is not a protocol we have to follow, but it's a drug dosage we have to follow and the number of drugs by different mechanisms. So they've correlated that if you're using more than 2 drugs, which work by specific mechanisms, the outcomes are going to be much better. And they've also shown that if you reach the GDMT guideline dose of those more than 2 drugs, then the survival, long-term survival is going to be much better. So I'm also going to introduce you to heart failure, what terms are used these days. So we don't use low and high cardiac output failure anymore. We use heart failure with reduced ejection fraction, which is HFRF, and heart failure with preserved ejection fraction, which is diastolic hypertension. Diastolic heart failure, which is basically what happens in adults due to hypertension. That is preserved ejection fraction, HFpEF. So these are the 2 terms which we are currently using. The treatment modalities, the 2 being completely different. So if you have a child with restrictive cardiomyopathy, you would have a preserved ejection fractions compared to a dilated cardiomyopathy. So what are the drugs available to us? ACE inhibitors, ARBs, and ARNIs. Too many acronyms. One single table will clarify all of them. We love to use beta blockers. Carvedilol is a drug which has been correlated to long-term outcome and management. RAS activation system, which is totally turned around, which causes vasoconstriction, sodium retention, left ventricular remodeling, and oxidative stress, is the one we want to suppress. How do we suppress it? Via ACE inhibitors, working on ACE directly here. ARBs work on AT1R, and there is a new group of drugs called ARNI, which I'll be talking about very, very briefly. And they also work in AT1 and one more drug. So sacubitril valsartan is the drug which is turned around completely. We don't use, it's been more than a year, I haven't used or written enalapril to any patient, because sacubitril valsartan is a combination of 2 drugs which work with different mechanisms but have fantastic outcome in terms of improving cardiac function. The patients where I couldn't get the cardiac function to move up or their activity, or couldn't get weight gain over a year in those patients because of their chronic heart failure, I started using this, and amazing results. Not only did the heart function improve, they gained weight, they gained height, which is a tremendous turnaround for the parents also. Little on the expensive side, but nothing most of our patients can't afford. So they work through the AT1 receptor, and sacubitril also leads to increased level of angiotensin, which is what we don't want. Therefore, valsartan is added to it. And mineraloid receptor antagonist, the MRAs, that is aldosterone, is the cornerstone of treatment, the only drug known to always improve lifespan of patients, cardiac patients. No other drug has proven consistently in every study to improve the lifespan of the patient, not just the quality, the lifespan outcomes. So the mineralocorticoid receptor antagonists are an essential component. In adults, there is a problem with renal issues and potassium going high, not so in pediatric. Aldosterone levels are 20 times higher in heart failure patients. Eplerenone is another wonderful drug, does not have the progesterone side effects of aldosterone. And it is the only drug which modulates fibrotic scarring in the heart, which is what happens in dilated cardiomyopathy. So cardiology is intoxicating in terms of sedative also. Everyone's ready for the sedative effect. No, heart failure doesn't end here. Have we had patients who've had Impella device implanted, HeartMate implanted, undergone ECMO? Yes. And you never know when your patient may need these. But there are other things in chronic heart failure a patient might need. If he has arrhythmia, we might need an implantable cardioverter defibrillator, just like the way we implant a pacemaker. It is an advanced pacemaker. Or we may need cardiac resynchronization therapy. What is this term? Are these just to confuse everybody, or is the industry just making big money out of cardiologists who are ready to play the game? No, there is a lot of science to it. CRT is basically ventricular crosstalk. When one ventricle doesn't work, the other one tries to make it work, and ultimately that also fails. So how do we resynchronize them together? By pacing them at a particular way so that they start working together again. And that is CRT. It's a very advanced science, a lot of calculations involved. Not all patients can have CRT. Basically, if you have a patient with left bundle branch blocked, so if left bundle branch is blocked, the electrical signals are going after the right ventricle is depolarized to the left ventricle. So the left ventricle function decreases because of this delayed depolarization. So you repolarize it early by pacing specifically the left ventricle. And that is CRT therapy. You might be having somebody in your family or in your relatives who've had a CRT implanted because of decreased cardiac function, magically improves the heart function from 25–30% to even 50% and changes their lifespan. So won't emphasize much more on this. ECMO and VAD are available. That is something to increase your spectrum of what can be offered to a patient when he's just slipping out of our hands. And heart transplant. 2 of my patients have had heart transplant in the last 5 years. Both had to go to Chennai. One of them was a doctor's child, and unfortunately, the father, an anesthesiologist, gave this 15 kg child who had dehydration and dilated cardiomyopathy. It completely improved from the dilated cardiomyopathy. She got dehydrated. He gave her 1 liter of IV fluids, and she never recovered after that. It required intubation, ventilation. He gave it in about 1 hour period, and the heart function just bottomed out completely, and her cardiac output dropped. And finally, she had to be airlifted, sent for heart transplant. It's doing very well now. This was about 4.5 years back, and he's shifted from anesthesiology to spreading the word around about CPR, and he's now more into CPR training of doctors and CPR training of the common man. He thinks there is something magical that's happened to his child, and obviously it has. The second is a child who had dilated cardiomyopathy, and unfortunately during COVID couldn't get the follow-up that she needed and had an acute illness of abscess in her axilla, and the abscess was drained. For some reason that time echo could not be done, and subsequently when she recovered and came for follow-up, and this is all happening when the Gurgaon border could not be crossed and things like that. She came finally, and the heart function was very, very low, and she rapidly deteriorated after that. So acute illnesses in a stable dilated cardiomyopathy can really result in a situation where we lose our patient. So heart transplant is available. I have 2 patients who are getting ready for heart-lung transplant as we speak, including 1 day before yesterday. I had the second counseling session with them. These are realistically available in our city also. So we are gearing up to start doing heart-lung transplant in our Eisenmengers and heart transplant in pediatric patients. 1 pediatric, very small baby who is about 6 months old, but a foreign national, has had heart transplant done in the hospital I visit also. So this is happening right here. Children need not necessarily die because of the lack of it. I get messages of heart being available of various ages practically every day. So these are available more frequently than before. Yes, they are available from a bit distant. There's one more advancement which has happened, and that is perfusion of heart while it is waiting to be transplanted. So you explant a heart, and then we used to put it in ice. But now we are perfusing the heart during the transport process, improving the time between explantation and implantation. So that, and this technology is not being used in India yet. It's just come this year. And what is in the future is obviously very interesting. And all of you have read about it, big heart in human being, etc. Well, that is chimerism. So we have genes which are going to go against our body, and those genes can be removed and can be replaced with human genes. So a big heart can get in. But then there is a collagen structure which can be used because that we won't have immunity against the collagen structure, which is a basic protein, which is the same generically in all species. So they've preserved that and muted certain genes using CRISPR technology of genetic modification, and that's where we are headed. So there is a time, maybe in our lifetime, when you could get a customized heart made. That here is my gene, give me a heart which is of my genetic makeup. What is the other possibility? At the end of the day, heart is only a pump. Brain isn't. Brain is all connections. Connections are difficult to make. So there are already mechanical hearts. We looked at HeartMate. If you go to YouTube, the pulseless man, if you just type, you see a 6 foot tall, almost a 200-pound guy who's totally muscles, and he's weightlifting in the gym. And he tells you that it's been 10 years, he's pulseless. And he tells you that he's got a battery pack on his back and he's got a LVAD in his heart. Heart doesn't work. So we are not looking at these as bridge to transplant. We are now looking at these as destination therapies. So two different terms. Using an ECMO is a bridge. Using HeartMate, which is a left ventricular assist device, is used to be a bridge with a longer bridge, and then do the transplant, but now is becoming a destination. There are children who've lived in US who've lived 4 or 5 years with a HeartMate on. So what about newborns? What about small babies? The clinical trials have started for implanting transcatheter, a small heart pump in the ascending aorta, the size of the upper part of your ball pen. And you see how that clicks? That's exactly the technology we'll use. I mean, more sophisticated though, that it'll click and get the blood in and then click again and push the blood forward. That's the technology which is being tried for 10 years now. And we are almost at the point where it could be used in pediatric patients. Human trials have started. Okay, last few points that I'd like to highlight is if you've had a patient who stayed in NICU, then bronchopulmonary dysplasia is something you need to look at. Echocardiography is the modality by which you can evaluate pulmonary hypertension in these patients. Why is pulmonary hypertension important in these patients? Because in extremis, because survival is highest in those who did not have pulmonary hypertension versus those who had severe pulmonary hypertension. Practically all of them died. Severe pulmonary hypertension, very high mortality. No pulmonary hypertension, best outcomes. Get echocardiogram these patients, ex-preemies who've received oxygen or have been on the ventilator. I do come across, including medical personnel's babies, nurses, technicians who have BPD and their pulmonary hypertension has gone undetected, and they come very late and have lost their child subsequently because of that. So echocardiogram assesses pulmonary hypertension very well. This is a very interesting and one of the best studies I came across. Incidentally, I reviewed last 1 year's literature to get you all the best studies that are there. So association of childhood growth hormone treatment with long-term cardiovascular morbidity. So this is interesting. This is a nationwide study of 3,408 patients treated with growth hormone over a period of 25-year follow-up in Sweden. And they had age-matched 15 controls for every patient. Total 50,000 patients were studied for cardiovascular morbidity and mortality. And what they found was the primary outcome was the first cardiovascular event. Conclusion was that these patients who have received growth hormone due to GHD, SG, or ISS, that is idiopathic short stature, was associated with increased risks of cardiovascular events in early adulthood, particularly in women. However, conclusions of causality are still limited and absolute risk remains low. So they had a significantly higher incidence of heart disease in these patients. Incidentally, those children receiving growth hormone, which affects the heart also and causes hypertrophy, need to have echocardiogram done. These are the patients I get to see occasionally once a year who would come for follow-up and get their echocardiograms done. Hypothyroidism is the commonest diagnosis you will make related to endocrinology in terms of what do you do related to heart. This is a study from India, from Wadia Hospital, Mumbai. Septal hypertrophy in half the patients, left ventricular posterior wall hypertrophy in 43%, LV dilatation in 1/4, and cardiac dysfunction in a small percent of patients. So hypothyroid patients, especially if diagnosed late, need to have this looked at. I've seen pericardial tamponade secondary to hypothyroidism. Rheumatology, we're talking about three main conditions, and very surprising news about these three. Obviously, we screen all these patients for heart involvement. They have verrucous endocarditis, pericardial effusion, valvulitis, or even pulmonary hypertension secondary to lung involvement in some of these patients. But this study was rather disturbing that cardiovascular risk in pediatric onset rheumatological disease is very high. So what they looked at various markers, and they say the incidence may be 300 times higher when a rheumatology patient grows up and gets into adulthood, and their incidence of coronary artery disease very, very high. So they need more lifestyle modification factors and drugs to regulate their cholesterol, triglycerides, and HDL and LDL, all of these, so that in adulthood, their coronary artery disease is much less. So what happens to hematology patients? We're not going to talk about thalassemia patients getting an annual echocardiogram. There's something more happening, and that is cardio-oncology. Now, this doesn't mean the cancer of heart. It means the effect of cancer treatment on heart. So this is a new field in adult and pediatric cardiology. There is a fellowship of 1 year post-pediatric cardiology training in US on this. What do these people do? Do they waste time, or they do really something different? Well, 30% of patients from cancer who survive long enough will die of heart problems. And the heart problem is that they have dilated cardiomyopathy. It's related to several factors, including radiation, including chemotherapy. Some drugs, doxorubicin and anthracyclines, are the primary cause of it. So what can be done? There is a new way, and here is a list of certain drugs and their side effects, which I'm sure all of you are familiar with. But this is what these people do: tailor cancer regimens, so they monitor the heart even during treatment, develop novel therapeutic techniques, and there are a lot of things which are happening in that area. Preventive strategies, optimize cardiovascular risk factors, and cardiotoxicity surveillance. This is what I will focus on. That is 2D, 3D echocardiogram with advanced imaging modalities. What does this mean? So you'd say, okay, you look at the ejection fraction, so what? We've been looking at that. But studies have shown by the time the ejection fraction is affected, you've lost the battle already. The heart's already on its way down and you cannot reverse it. How do we detect it at the earliest? So death rates attributable to cardiac cause are 8 to 10 times as high amongst cancer survivors, childhood cancer survivors. And what we are looking at late adulthood is those who had treatment in 1990s. Half of childhood cancer patients got anthracycline. More than half of survivors treated with anthracyclines have echocardiographic evidence of abnormal cardiac structure and function. 1/4 and half of all childhood cancer survivors have cardiotoxicity. Now we are missing out all these patients. You all have worked so hard for them, and their hematologists worked hard, but they will end up with cardiac problems, some of them, unfortunately. And how can we detect it at the earliest? So there is obviously online available cardiovascular risk calculators, but the modality which is coming forth, and that's another new technology which I'm talking about, is global longitudinal strain. So this picks up cardiac dysfunction much before ejection fraction decreases. It has emerged as the earliest marker for all cardiac dysfunctions, be it dilated cardiomyopathy, myocarditis, everything. It's all now by GLS. So GLS is more sensitive, more reproducible than LV ejection fraction. I'll show you a short video of it, what happens. So this is, we get the basic echocardiogram, and then I'm supposed to move to the 20th second here to show this to you. So here you will see in a short while, yeah, this is what it is doing, what is called a speckled tracking. So this is automated tracking of every single speckle which forms the myocardium. Basically, speckle is a dot which reflects ultrasound wave. So we have now ultrasound machines which can carry 40 million signals per second. These are the kind of echo machines which are available. If this is not used, then you cannot do this analysis. GLS, global longitudinal strain. So if you know somebody who's having an echocardiogram done for function, be it someone in your family, you will find adult cardiologists doing this. And if you don't, you should ask for it. And most of your otherwise pediatric patients can also have it done at our place. GLS is something we have asked for and acquired the machine for it. It is expensive, but I decided that that's something we need to not stay away from. So this is how GLS is done. It tracks the border of the heart itself and gets signal from each and decides how much is each of those speckles moving, and then makes a chart like this. And it's the negativity of it which counts. So if it is 18% or lower, it's better. If it's less than 18% shortening of the global longitudinal strain, then we are in trouble. So this is something that you need to look at. I think I'm going to forego a bit of the rest of the talk. It's been a bit too much, is it? Yeah, I think I'll forego the rest of it. We don't need to talk about, oh, this is these few. We have valve replacement available in our city. We have pulmonary and tricuspid valves, which are replaced transcatheter in the cath lab, not surgically. Mitral and aortic, not yet in pediatric. These are pictures of the same being done. And large studies, also same. Heart transplant, I've already talked about. This is a new modality of ventilation called CORONARY ventilation, which is biphasic ventilation, non-intubation ventilation, being used in single ventricle patients. You can see how this works, and this is home ventilation. This is something which will help single ventricle patients get off positive pressure ventilation, which is actually the non-physiological way to ventilate. We have negative intrathoracic pressure when we breathe, but the conventional ventilation is all positive pressure. So this works on physiological ventilation as compared to positive pressure. That's the end of it. Thank you very much. Sorry about the length of it. Yes. GLS already. It's proven, sir. Yes, sir. Already studies are there. Pediatric GLS is the earliest marker. Yes, sir. I did not decide to invest in a new machine just like that. The technology's changed completely, and if you don't have it, we're technology driven. If you don't have it, you can't deliver it. So, what is the source of transplant you're using for heart transplant in children? Oh, no. It's not there in clinical use, but that's research. Human to human transplant. Yeah. So brain dead people. Yes. No. Cannot use a cadaveric heart. Brain dead. So road traffic accident. Road traffic. So it is, the process is very intricate. So brain death has to be declared by 2 neurologists. Yeah, same way. Yes. So kidney is human to human transplant is possible, but living related donor is possible. Liver is possible. Heart living related is not possible. There's only one now.
Very nice talk, sir.
Thank you.
Thank you.
So the 5-year survival is almost 80 to 85%. 10-year survival is almost 75 to 80%. The problem starts in teenage years. They become non-compliant with their medicines. If during teenage years they're compliant, the survival beyond that is the same, 75 to 80%, 20-year survival. So of most organs, heart has a pretty good survivorship as compared to lungs, which is the least survivorship.
What is your opinion about use of IVIG with Kawasaki in prevention of coronary penetration?
Universal, we have to use it. We have to prevent coronary disease. Yes. Once you suspect or think of Kawasaki, treat it.
What is the quality of life after heart transplant?
So usually a patient who has heart transplant is NYHA class 4, which means they are short of breath while walking, talking, eating, food, bathing, changing clothes. And that is not a very good condition.
Is it worth it?
Oh, yeah. Absolutely.
When the quality of life is so poor and you're not going to survive for 5-7 years.
No. See, I have been with parents in both the situations who have lost a child and then whose children have survived and subsequently lost. What I have learned from parents, actually, I admire these parents. What I've learned from them is they've come back and thanked me. They've said, thanks, doctor, you gave us few more years with our child. So that is a commercial end of it. I'll tell you the spending. It costs around 20-25 lakhs, and 1 year's medicine cost is about 1.5 to 2.5 lakhs.
27 lakhs for 5 years.
So I don't know those exact numbers, how much they will spend over 5 years. So it's for parents to decide whether they want to spend it. Yeah, I'm not saying everybody should get it. I'm not here to doubt the commercial end of it. This is a scientific discussion where I've told you what are the advances in science available to us today.
What is the dose of Brufen in PDA and UMH?
So 3 doses, 1 dose a day. 10, 5, 5 is the initial dosage, but if you want to use higher dosage, that is 10 milligram per kg first day, 5 second day, and 3rd day. But if you want, this has about a 72 to 80% closure rate. If you want about 85% closure rate, you need to use 20, 10, 10, and no added side effects. 3 days. What I do is I give 10, 5, 5 for 3 days. If it's become small enough, it's good enough. If it's not become small and the patient still significantly symptomatic, I go to the higher dose and give the second round higher. Next day itself, no gap in between.
For how long should you be following up the kids with growth hormone?
So during the phase when they receive growth hormone, one needs to annually check for hypertrophy of the ventricles. And subsequently, it is more monitoring for coronary artery disease, which is early onset in these patients. So there you need to look not specifically at the heart, but more at the carotid intimal thickness, which can be done once in 3 or 5 years. Well, it would continue through the next several decades. They followed their patients. That's one of the best studies I came across.
Yes, you shouldn't be very apprehensive about this sharing. This is something we see very common. Treated with steroids. Should we be apprehensive about myocarditis infusion?
So, are you referring to juvenile rheumatoid arthritis and use of steroids? That doesn't cause myocarditis. I'm not sure.
GRA invariably goes up. Correlation of GRA with myocarditis incidence is much.
No, I didn't say that. I'll go back to that slide if you want. So there are 3 conditions which have been studied: lupus, dermatomyositis, and one more condition which I showed there. These conditions were studied because of the treatment they received, which includes a lot of immunosuppressants and steroids. The steroid per se doesn't cause it's not myocarditis, it's coronary artery disease, early onset. And atherosclerosis, early onset, very high incidence. Yeah, maybe I misspoke. I was also talking about.
Myocarditis usually due to virus.
Yes, but toxins, and drug side effects. And we recently lost a patient with fulminant lupus presenting for the first time with myocarditis and fulminant arrhythmias. Absolutely untreatable arrhythmias with any drug which are there available. So autoimmune also.
Thank you, sir. Thank you for very nice. Thank you, Dr. Devasita. Let's have dinner.
चला लेते हैं.